Hello, everyone. My name's John Applezahn. I'm originally from Indiana. I got my undergrad in exercise physiology at Purdue, and then went to foods and nutrition and got my PhD there, and then went on and got my master's in clinical research at Tulane. And I've been here for about 13 years at Pennington Biomedical.
I'm Jason Collier. I'm a Louisiana native. I grew up in Denham Springs, went to Denham Springs High School, went to LSU, got a degree in biochemistry, went down to New Orleans, got a PhD in biochemistry, and then I went off to Duke University Medical School to do postdoc in pharmacology and islet biology. I took my first faculty position at the University of Tennessee, but that orange color is a little bit obnoxious. And, had an opportunity to come back 12 years ago to the Pennington. That was a dream job for me, and so I took that job, and I've been here ever since. And I'm currently an associate professor and director of the islet biology program.
Good morning, Robert Dubin. I am an endocrinologist, and I basically am from Florida originally, but I did my training in endocrinology here at LSU, so that was about 15 years ago. I came back 2 years ago to do research, and I do mainly weight management, and we do a lot of work with patients with diabetes, and a lot of men's health stuff kind of is intertwined there, weight management and diabetes, so glad to be here.
Right, my name's Tim Gilbert, also a Louisiana native from Lake Charles. As Bob, I'm a endocrinologist. Went to med school at LSU in New Orleans, did an internal medicine residency here in Baton Rouge when Earl K. Long was still in existence, and then trained endocrinology and metabolism at Ochsner. Spent 20 years of my career in private practice back in Lake Charles, Louisiana, and then recently joined up with Pennington last fall to start Pennington's first outpatient endocrinology and diabetes program, where we are kind of mixing a model of true outpatient care, also with research opportunities. So I serve both as the director of the outpatient endocrine and diabetes clinic, as well as a clinical research physician. And kind of across the board, general endocrinology, diabetes, testosterone, et cetera, pituitary, adrenal, thyroid.
Awesome, thank you guys. So I have a few questions here I'll start with to kind of get things moving. And again, feel free to raise your hand and ask any questions as we go. So I'm gonna start with Dr. Applezahn. Physical activity and aerobic activity comes up a lot. Will aerobic physical activity be extremely helpful on a weight loss journey?
So, So usually in terms of weight loss, physical activity is critically important for your overall health and general health. But for actual weight loss, it helps it's about 20% of the weight loss journey, give or take, is what they've found. You lose about, if you're in a lifestyle program, something like that, about 20% of the weight loss comes from exercise. And if you just start an exercise program without any sort of dietary intervention, you're going to lose a small amount of weight. It doesn't mean it's not going to help your overall health, but you're not going to lose massive amounts of weight just by starting an aerobic exercise program, if you will. So it's definitely recommended, but it's not going to involve, don't frame it as a weight loss program, because you're going to be woefully disappointed.
Well, I think what Dr. Applezahn is trying to say is we live in South Louisiana. We like to tailgate. We like to have Mardi Gras. When people are in January doing New Year's resolutions of I'm going to eat better and I'm going to exercise, what are we doing in Louisiana? We're rolling out king cake.
Yeah.
So if you can curb some of those fun things we do here at the eating and drinking level, put them in moderation. Nobody says you have to stop, and add a little bit of exercise. That's where you get the real benefit.
Can you touch on or define for us metabolism?
Sure. So a lot of times you hear, hey, my metabolism slowed down, or, how do I ramp up my metabolism? And so what does that mean? And when we talk about metabolism, it's really just the way your tissues and cells process the things that you eat and drink, okay? And they turn those food molecules into energy, right? So if a chemical process from A to B takes 6 hours, the enzymes in your cells that control your metabolism will do that in seconds to minutes, all right? So you're able to do it much faster than it would normally occur outside of a living system. So metabolism is collectively those series of chemical reactions that turn food into energy, right? You don't eat for a long time, you feel weak. You eat something, you all of a sudden feel good, that's turning that food into energy, and that's collectively called metabolism.
Okay, so just.
I think we have a question.
Oh, perfect.
Oh yeah, I was gonna ask, just related to metabolism, how to think about metabolic function as someone who wants to stay healthy. You know, there's lots of talk about metabolic dysfunction becoming a thing people are looking into. Should you take CoQ10 to help your cells do better metabolism? It doesn't seem like what I've seen of CoQ10 doesn't seem like super, like the research is conclusive on that it's something you should be taking. But I was wondering if you had any thoughts on, you know, how the general person should think about metabolism, keeping metabolism healthy, and maybe supplements like CoQ10.
Yeah, so those are great questions, and I think a lot of people want a supplement or a supplement stack as a turnkey fix for something. And the reality is you've got thousands of chemical reactions going on inside your body, and a CoQ10 example would be adding what's called a cofactor, which just helps a protein do its normal function. You're adding one thing in a big barrel of 1,000 things, right? So it's hard for that one thing to really adjust something metabolically that you're going to notice. So to answer your question is, how do you sort of ramp up your metabolism or have healthy metabolism, maybe a better way to put it, would be to eat what we consider a healthy diet in moderation. In other words, if you're going to McDonald's 3 times a day, we all inherently know that's probably not good, right? And so if you're not eating any fruits and vegetables and you're not getting any physical activity at all, if you sit on the couch and eat cookies and watch football for 8 hours, you're not really moving around, your diet's not great. But if you can start from something small and just do something, go from sedentary to just taking a walk or riding your bike, it doesn't have to be crazy intense. Just do something. That's a start that has huge benefits for your health, like Dr. Appleton was talking about. And then if you just changed something in your diet, like you just eliminate fast food, for example, like a lot of those saturated fats and processed foods, and switch it to, the easiest way to think about it is eat things that don't have ingredients. If you buy a steak and you buy a potato, there's no ingredients. That's a steak and that's a potato, right? Or chicken or whatever. Eat healthier really just means trying to eat unprocessed foods, if that is something people feel comfortable with as a general idea. And I would say most people, from a common sense perspective, kind of know that, but you're kind of busy and it's super fast to run through fast food and have that dropped in your car and you just go straight home and eat. You don't have to cook anything. You don't have to go grocery shopping. And so it's taken a little bit of a time to invest in your health that really matters for your overall metabolic health.
And beyond that, supplementation for metabolism is not necessarily something you would recommend at this time?
If you have a deficiency, then it makes sense. But if you have a normal diet that provides all of those things, I don't think putting it on top, if you're already sufficient, adding extra is probably not going to give you much benefit. It's really when you're in a deficient state that adding it makes sense. I'm not offering clinical practice recommendations, just as we have 2 guys that could do that part.
So another way I like to think of it too is, what's the most studied supplement in the US or the world?
I would guess creatine.
Both of those are baby formula. Hands down, has been studied the most in terms of a supplement. Would you rather have breast milk or baby formula?
Presumably breast.
Exactly. So that's the way you need to think of your diet as well, is if the most studied supplement is not up to par, then probably the other supplements are not. So I think it's exactly that, a supplement, and not something that should be instead of real food, because we can't replace real food, if that makes sense.
Yeah.
But it's not we're not bashing the supplement industry, because there's probably 3 to 4 that are getting more and more credence as possibly positive, but overall, in the grand scheme of things, I think there's that. And the other thing is, we see the flip is things like vitamin C. They've unfortunately pretty much reduced, not taken away the upper limits for lots of the vitamins and minerals. And bladder cancer and things like that are on the rise. And it can be actually linked to an over supplementation in lots of cases. So I think there is such thing as over supplementation as well, when you're trying to do things that people need to be a little bit more cognizant of.
Okay, last question related to that, just 'cause it is
Yep.
direct, and then I'll yield. Sorry.
Good question.
Multivitamins.
Yep.
I tend to take a multivitamin just at least every couple of days
Yep.
as insurance because, you know, I'm worried about even
Yep.
eating healthy, nutrient depletion in soil is, you know,
Yep.
something that's being studied more and more. Would you go so far as to say that even a multivitamin would potentially go the other direction if you're already eating healthy towards too much?
I think each of us could probably have a different answer on this. I would not, especially but it also depends on what else you're consuming in your diet. Because what starts to happen is people consume a multivitamin, then they'll consume, some vitamin and mineral, supplemented shake, and then they'll have, so if you're not doing those other things, then I think a vitamin and multivitamin is fine. But if you're doing a variety of other supplementation during the course of the day, it's just something to be cognizant of, would be my response. But that probably has three other different answers.
Yeah, I'm curious.
No, I think that's fair. I was just going to add one sentence, which is if you're just taking the multivitamin and you're not deficient in anything, your body's got good excretion mechanisms. It's just going to get rid of, typically, the water-soluble vitamins are going to just get eliminated for which ones they don't need. Fat-soluble vitamins, you'll get more of a storage.
And I've seen vitamin D, the fat solubles, A, D, E, and K. And I have seen vitamin D toxicity on a number of occasions. I mean, I'm quite sick, like hospital sick. So it happens, and it's become used to. You could only get 1,000 unit or 2,000 units over the counter. Now you can get a 10,000 unit capsule over the counter, and people think, what's a vitamin? More is better. What happens is vitamin D goes up, calcium goes up, patients get nausea, vomiting. They look like they've got cancer for all the way. They start losing weight, and that's a lot of the admissions turn out to be workups for malignancy, and then they're found to be, so more is not always better. And it's the concern about the patients that come in and see the dietitians, and they've got, a size like a banana box full of supplements. And I'm amazed at how they can eat because of how many pills they take, or that they don't rattle when they walk, for the number of pills that they take.
So 5,000 IU, 10,000 IU would go so far as to say maybe.
I would say it depends on your level, but I definitely wouldn't. Most people, 1,000 to 2,000 units a day is more than adequate. We do those higher doses for patients who are deficient for a certain amount of time, and then I'll usually do like 10,000 a day for 3 months, recheck a level, and when they're above 30, then we'll cut them back down to 1,000 to 2,000 a day. Yeah, 30 is
Some people say like 60 is what you got to aim for.
30 to anything over 30. You're not really, in my opinion, not getting much of a metabolic benefit over 30.
Okay.
Yeah, and remember, if you're out in the sun regularly, your body makes vitamin
vitamin
D,
D.
so you wouldn't need a supplement. I mean, this is for people that have trouble.
Yeah, sunscreen
Well, that's the
cuts
thing,
it,
right?
yeah.
That's the thing.
Yep.
And as we age,
Yeah.
we convert less vitamin D in the sun as well. So,
Interesting. Okay, thank you.
somebody had a question?
What is intermittent fasting?
So, do you want me to take that, or?
You want to start? Go ahead. Anyone go? It doesn't
Intermittent
matter.
fasting is just a prolonged period without taking in food. All right, so while you're asleep, for example, you're fasting because you're not eating. Intermittent fasting is just a phrase that's just asking how long do you want to extend that period. So if you normally sleep 8 hours and you're not eating, but then you wake up and you skip breakfast and you go all the way to lunch, and that may be 16 hours, that's now 16 hours you didn't eat, and that is an intermittent fast because at some point you're going to eat. So it's intermittent between the next meal.
Is that recommended now? I hear so much about it.
I think that's a great question. You want to take that?
So, yeah, I agree with Jason 100%. And intermittent fasting can be similar to time-restricted feeding. So, like increasing the amount of time that you're not during the day. It can also be on certain days you eat less than other days. So you would eat. I would eat 100% of my recommended calories today, but on, say, Monday, I would go down to, say, 50 or 75%. And so that's another way to do intermittent fasting. That's the kind of the two ways. I would say I think especially intermittent fasting, I don't think is harmful, especially because most people tend to actually do it automatically. You have about a 2 to 4 day lapse in your eating. And so most people eat a little bit more on the weekends. And so naturally during the week, they eat a little bit less. So you're probably doing it without even realizing it. And so if you would take it a little bit more, I don't think that's negative as long as you don't have any history of eating negative eating behaviors or anything like that. I think that's positive, and more they're finding eating at night and these short eating windows are detrimental to health, especially when looked at chronically.
But also, just before we turn it over, is anytime you're thinking about changing anything that could overall affect your health, it's a good opportunity to talk good about it with your clinicians. And I'm pointing to
Yep.
these two guys because they're going to provide clinical practice recommendations. We're not. Because there's certain medicines you might be taking and they might be indicated
Yes.
for a certain time of day. And if you want to start changing the way you eat, you're going to want to discuss that with your doctor to make sure that won't affect any medications you're on or any other therapies that might be needed to be monitored on top of any time you eat.
I would expand on that eating at night. You mentioned eating at night.
Yeah, that's it. Do you want to respond to the other part first?
Well, I think clinically speaking, the key factor here is individual recommendations. When you go online and you look, what kind of supplements should I be taking? It doesn't know who's writing that, and they're just going to say vitamin D, 1,000 units a day, blah, blah, blah. This gentleman over here, he looks very healthy, he looks very young. The chance of you having a vitamin deficiency, man, the supplement market is all over you, man. It's $1 billion a year supplement market. You probably don't need any supplements, but I don't know. You might have some sort of absorption problem and have B12 deficiency. So it comes down to sitting down with your doctor and looking at you, who you are, deciding what you need. Because all the questions we've had so far are very generic. And I love what Dr. Collier said. It depends on if you have a deficiency. Yeah. Same thing with intermittent fasting or time restricted. It might work great for you, but it might not work well for somebody else. So that's the beauty of going to your doctor, talking to them, and saying, hey, it's me you're sitting in front of, not Google, right? I hope that helps.
Yeah, and be honest with your doctor about how you feel, because they will know what blood tests to order.
Yep.
And sometimes blood screens will pick up a deficiency, and that's something like, say you have a zinc deficiency. Well, that's somewhat easy to fix. And your doctor, based on your symptoms, will treat you and know what test to order for you, and that's big. I think a lot of people are afraid to go in and hear the answer, but a lot of times the answer could be simple. Yeah, we go.
Yep. Do
We have a gentleman over here first.
Oh, sorry.
Yeah, and then I think this guy too, and then we'll get to you. So gentlemen, yeah.
Oh, yeah.
You mentioned eating at night. Eating at night is not good, apparently, what you're saying. Or how late can you eat at night?
Midnight snacks.
So basically breakfast is breaking the fast. And so evolutionarily, they're kind of finding that your bodies were used to having a true fast during the course of the night. And since in the modern ages, we have lights, we have microwaves, we have everything. So people can eat a lot later than they traditionally did and historically. And so your eating window has shortened dramatically. And they're finding more and more that is having negative health benefits, that actually even expanding that fast just a little bit has likely a lot of health benefits. I mean, we're not definitive on this yet, but it's looking pretty promising, if that makes sense, in terms of the overall research. And so it's becoming more and more recommended if you can, have at least a 12, 13 hour window between when you ate dinner and when you ate breakfast, it's going to be healthier. And if you can go like an hour or two longer, it's even better. But you're most insulin sensitive in the morning, so the goal is not to eat lunch and then eat dinner real late. I'm not suggesting that at all. I'm suggesting you want to eat in the morning and then cut it off in the evening at a reasonable time would likely be, in terms of, like Bob said, Dr. Dubin said, sorry about that, normal, you want to look at your individual and what works best for you, because you don't want to gain 15 pounds changing your diet, starting eating breakfast or something, because that wouldn't be healthy. But in terms of overall recommendations, that's kind of what we're looking at in terms of the future as best practice or something similar to that.
Don't eat at night.
This gentleman right here.
You're touching again
Yeah.
on intermittent fasting. Is there a better food to break your fast with, say protein, or should you combine the proteins and
Good question.
Yeah.
I think the one thing, go ahead, Lucy.
Okay. So for satiety, for you to feel full and satisfied, you're going to want something that's got a good combination of protein, carbs, and fat. So it's, the donut and coffee, for example, that you might grab, that's going to spike your blood sugar, and then
Yeah.
probably an hour or two later, you're going to be hungry again. But if you can get something in that you like, that's, say, like an oatmeal, a hard-boiled egg, whatever it is that you particularly like that has a mixture of protein and carbs and fat that allow you to have a, you should mix them all. Your body's designed to run on all three of what we call macronutrients, which is protein, carbs, and fats, right? And the more you can do that as you're breaking the fast, you will get a satiety signal. You'll feel full and satisfied, and you'll be less.
You were saying, you can go on the internet and find the answer that you're actually
Yeah.
looking for.
Yeah.
Protein,
Yeah.
so it's confusing.
It is.
is. But I think everything in moderation is perfect. And like you said, a balanced meal in moderation. Because we will find, I will say protein is the bane of my existence most days. They may not feel the same way. But most people come in and the guys are saying, they want to eat 300 grams of protein a day or something ridiculous. And they think it's the best thing for them. So I think eat a balanced meal for sure, but everything in moderation. You don't need to eat a steak for breakfast, lunch, and dinner to be the best and to get your protein needs.
All over.
Yeah, you're good, yeah.
A couple questions related to weight loss and obesity. So I know when we're born, we have a certain amount of fat cells, and then through childhood, we gain some more hyperplasia. I'm curious, so having lost a significant amount of weight myself, I know that, again, those fat cells, they hypertrophy, they undergo hypertrophy, then they shrink later on, but they don't necessarily turn over time. I guess the first question is, they really don't ever turn over, right? Like even after decades is the first part of it. And the second part is, and it was a question, not a statement. The second part is, what's the effect size on someone that has those fat cells versus someone that doesn't when it comes to gaining weight, regaining weight? Should it be something that I should think about, be considering preparing for? Yeah.
You want me to start, or you want?
That was
That was very technical.
That was we actually
used
do
the word effect size.
Yeah. Which is
Who
good.
knows what effect size is? I don't even know.
I can start if you want, and you guys can jump in. There's no simple answer for one. Okay,
Right.
so you're thinking about it at a really detailed level. And I think that's good. One of the things that sort of brings up, since we've been talking about eating and timed eating and how much and moderation and types of foods, part of what controls your fat cell size is how much you eat. Okay, so while people don't like fat cosmetically, it's the correct place to store the fat you eat, all right? Because if you eat so much that you're starting to gain weight and fat, if there's excess beyond what you can store in the adipose tissue, which is what fat is, it will get stored in your lean tissue, right? So you don't want fat stored in liver, pancreas, muscle. Now you're asking that tissue to do its normal job and store fat. So what do you think happens? It's not good at its normal job anymore, and its overall health starts to deteriorate, right? So first, you want to store fat in your fat cells, all right? Now, the amount that you eat is going to drive your hormone levels up. So most people probably have heard of insulin. How many people have heard of the hormone insulin? Okay, most of you probably think of it as it's a hormone that controls my blood glucose, right? That's true, right? That's essentially what would be the common knowledge. But that hormone does a lot more than that. It's anabolic. It promotes lipid storage in your fat tissue, okay? It prevents lipid breakdown from your fat tissue. So if you have a large fat cell and you're fasting, you will use that to sustain energy, and that fat cell will shrink, right? But if you have a large amount of insulin circulation, it makes it hard for you to use that fat, okay? So to your point, which is there's no simple answer, and we could discuss this for several hours, you got to control the amount you're eating. And part of the time-restricted feeding we were talking about sort of helps with that. The longer you're fasting, the more you're using the fat you have in your body rather than taking in a source to sustain energy.
I guess as it relates to effect size, though, for like someone, I don't pretend to know your history with your weight, but I imagine because I have the fat cells having been created, I can more readily gain that weight than maybe someone who hasn't ever been that weight. I'm curious to what is the size of that effect?
So you can, but it's not due to your fat cells per se. It's due to other hormones and likely mostly due to your brain.
Okay.
Is why. So your fat cells, they do turn over. They just don't disappear. So they're still there. And so there was a study done here. It was called EAT, and it actually looked at the differences between small and that was actually fat cell size and the effects on weight gain. But I think I applaud you for your health journey, and I think that's really good. But B, the biggest thing I think for you is to increase your lean tissue would probably be the same thing. So through resistance training and then aerobic exercise would be my two considerations over the long term, because that's the only way that your body's going to I call it re-equilibrate, but it's probably not the best. That's not the scientific term. But that's my recommendation. I don't know what you guys think.
I mean, to go to your point, I mean, I think we all have, your body starts developing we call metabolic set point, you know, and just I'm going to pick a number out there, say 350 pounds, and you lived there for a while, and then all of a sudden you, through intense diet and exercise or through bariatric surgery or through, you know, pharmaceuticals, you have this sudden weight loss. Why is it that, you know, the same person can gain and lose the same 50 pounds over and over and over to the equivalent of several hundred pounds in their lifetime? When you begin to lose weight, our hunger hormone, in response to weight loss, our hunger hormones go up, the satiety hormones, or the hormones that keep us full, go down, and our muscles actually become more efficient. Now, that sounds great, okay, my muscle is more efficient. But what happens is when your muscles become more efficient, they burn less calories, and then some studies will say 500 calories per day less in a basal metabolic rate. So all this sort of sets up this perfect storm for weight regain. You know, now, there's some experts that would say that, you know, getting at and achieving a new target weight and maintaining that target weight for at least 12 months probably at least helps to a degree reset that metabolic set point. You know, and I've seen it both ways. Patients will use pharmacotherapy for weight loss and get them to a target weight and maintain them on some sort of, you know, maintenance plan for 12, 18 months and then let them try to wean off. 25, 30% of those patients will be able to come off of therapy and stay off of therapy. And 65, 70% will need some sort of maintenance therapy. Going back to the fact that, as John pointed out, it's a lot more than just bad genetics or a bad diet. We know that being overweight or obesity is a disease. It's a true disease. There are hormonal factors at play. It's no different than having diabetes, hypertension, you know, dyslipidemia, et cetera. So, I don't know if I answered your question or not.
No, that's good. And I guess a follow-up on that, since we're talking about maintenance, this will be a simple one. Should be quick to answer. Pharmacology-wise, so there's a lot of anti-obesogenic peptides that have been coming out, right? So you got your like semaglutide, tirzepatide, single, double agonist. Now there's like retatrutide, triple agonist with the glucagon. And also I've heard of like Regeneron. I'm curious if there's any that you guys are particularly excited about, because I know that's a big thing in Pennington.
He's the man for that.
Oh, awesome, okay.
Yep.
So like, yeah, so of these anti-obesogenic drugs, are there any, like I heard about this myostatin inhibitory one, are there any that you're particularly like excited about that are being researched right now? Right now I know like retatrutide is like a big one that's coming out.
Yeah, I would say the retatrutide is the more is better case because it has 3 agents.
Right.
But, you know, we still have to get through the preliminary studies to see the weight loss effect seems very good. You know, one of the things, you know, listening to you, what was your first name?
Alexander.
Alexander, wow. You should work at Pennington. You've got a very inquisitive mind. You should look at the Lancet Commission on Obesity if you haven't, because not everybody who seems large or obese has a problem, right? They're trying to redefine obesity in terms of clinical, right?
Sure.
There's a lot of, you've probably heard metabolically healthy, obese, and all that stuff. So that's one of the things that the Lancet Commission really strives to do, is it strives to identify patients at highest risk for the disease of obesity, rather than just, you know, overdiagnosing everybody and say everybody needs a GLP-1. But yeah, we're real excited about the pipeline drugs, Alexander. They're amazing. We're hoping to put bariatric surgery out of business with these drugs. The problem is, Well, retatrutide what's a good one is,
Yeah, I know.
what is a
Person
good one,
specific.
Alexander, is not a GLP-1. It's an adipocyte-targeted drug, right? Why are we targeting food intake when you already have mentioned some of these metabolic features? So at Pennington, a lot of people are looking at mitochondrial dynamics. They're looking at direct adipocyte effects where we can, because personally, I don't think the GLP-1s are an ideal route to help people manage their weight because it takes away the enjoyment of food. Yeah, and it's not sustainable. So I think the answer to that question would be looking even beyond the incretins. The incretins are certainly great, the best we've ever had, and I think there'll be a role for them wherever this takes us. But in the future, it's going to be adipocyte focused, which is where we need to do.
Nice.
Great questions.
These are great questions. I want to pivot to a different subject, but you have one more follow-up on this topic, that's fine.
What are the good kind of fats to eat?
Come on over to my house and I'll show you. King cake, yeah.
Yeah.
Are you talking about or like unsaturated, polyunsaturated fat?
Well, y'all mentioned when y'all were talking about the different kinds of fruits,
Yep.
fats and
Yeah.
carbs.
Oh
and
yeah, so
protein.
good
Yeah.
fats would be like fatty fish, like salmon and
Yep.
tuna.
Yeah.
If you can-
Avocados.
Yeah.
Avocados, that's right. If you can use olive oil
Olive
instead
oil.
of butter,
Yeah.
Yep.
those are your good fats. If you think about it like this, if it's a liquid like an
Yeah.
olive oil, it's probably going to be healthy. You look at butter, it's a solid.
Yeah.
That's going to be a little bit worse for you.
Favorite.
Yeah.
All the things we typically like, etouffee's a butter-based roux, that tastes good. Right? South Louisiana, we have the best food probably in the world, so it's a tougher sell for a lot of us. But yeah, that's a good question of healthy fats. And which is
Healthy,
good.
okay.
Avocados,
Yeah.
guacamole.
Yep.
Good, I like that. That's a tasty one too.
Yeah.
Yeah.
It is. We're doing a study right now on avocados. I don't know if anyone's seen preliminary data on that. Yeah.
Cool.
So we
Sure,
more questions?
yep.
Speaking of testosterone,
That's what I was
I
going
know they say as you get older, it goes lower and lower. Is there ever a point where it levels off, no matter how old you get?
It's probably a question for you guys. That's probably person specific, right?
It is to a degree. I mean, as we age, testosterone level is going to go down. That's inherent. But also it goes down with our health. We can have someone who is very metabolically unhealthy. They're 30 years old, but they're overweight or obese, and they've got sleep apnea, et cetera, and they may have a total testosterone. Normal range is about 250 up to about 800. They're going to have a total testosterone in the 200s, somewhere that I would expect someone twice or three times their age to have. But yet, the LSU linebacker or pro football player who's the same age, who's very healthy, will have an 8 or a 900 testosterone. So health has a huge amount to do with it. Age has a big factor. I don't know that necessarily that there's some point or some magic age that it levels off at. I think, in terms of one of the questions that comes up often, I'll just preempt this, is why is it being diagnosed so much more than it used to be? Why are we seeing low testosterone? We didn't see it 20, 30, 40 years ago. Part of it's screening bias. I think we look for it now. I guarantee you my dad's doc or your dad's doc didn't, go in screening for testosterone. It's not one of those things that was on the radar when we had fatigue or things like that. So I think that's part of it. I think that lifestyle is a big piece of it. To John and Jason's point, I mean the things that we're eating, the quality we're eating, the time frames that we're eating are not the same as they used to be. We're eating much more processed foods. I think, Jim Gilbert's opinion, I think that has a role in it. And that we don't live in the world of Leave It to Beaver anymore, where Ward Cleaver comes home at 5 o'clock, puts his feet up and eats at 6, and he's in bed at 8 with no stimulation. We've got phones, we've got TVs, we've got computers, and all this external stimulus. And myself, for sure, I don't get 6 or 7 hours of restful sleep at night. So I think all those things play into it. Is there anything wrong with replacing? As long as somebody doesn't have a personal history of prostate cancer, I'm pretty liberal with replacing testosterone. Sometimes it's about quality of life versus quantity of life. Most of the well-done studies show that quality of life goes up And we typically either longevity stays the same or longevity gets better. There's some veterans studies that show that replacing testosterone in testosterone deficient men, even up in age, is a benefit because it makes the bones stronger, the core healthier, you're less apt for falls, you're less at risk for fractures, etc. So it can help on multiple fronts. So, hope that answers. That was a long answer to a short question. I apologize.
Well, yeah, no, sorry.
So I'm a baby boomer, so I'm getting more and more interested in anti-aging. Do you guys believe in supplements if you don't get all of the nutrition that you should be getting from just eating the foods? And does Pennington have studies going on which ties into anti-aging type of information? Trying to find
More
out.
John or Bob, one of those guys.
You want one of us to?
Well, you could start.
Yeah, so we, I don't know if you missed earlier, we commented on supplements earlier a little bit, and they work best if you're deficient in something. So if you think of a supplement, it's sort of adding something on top of your diet. And so if there's something missing from your diet, it makes sense to add a supplement to replace it. But if your diet is, I'll say healthy, that's sort of a catch-all term for you're getting all nutrients from the food you eat, then you don't necessarily need any supplements.
It just seems like there's more and more empirical data that's coming out with new, they're finding new nutrients and this and that would help prolong life. So I'm
Well,
interested in what you think.
Clinically speaking, there's a problem with the anti-aging science. Try to find someone who takes insurance who does anti-aging. You won't. Try to find somebody who does anti-aging that doesn't sell supplements in their office. You won't. So, yeah, anti-aging sounds great, but every one of those anti-aging doctors is growing old and will die just like the rest of us. So, I don't know. I'm not a big fan of anti-aging. The only way to stop the aging process is to die. But you could grow healthy, gracefully, and there's a lot of great things out there. But you know what they found that extends life? The only thing? What is it, guys? It's calorie restriction.
Yep.
Right?
Yeah, so yeah, absolutely, that's true.
So you believe in fast, intermittent fasting?
Well,
It's a person-specific thing,
Yep.
but the only thing that extends lifespan across all, I mean, you're talking worms, flies, mouse, rat, monkey, human, is caloric restriction. And I think personally, I'm going to speak as my opinion, that is because the better your health is, the greater chance you have of longevity. Because essentially longevity, from my perspective, is avoiding a chronic disease situation or an acute disease that would kill you soon, right? So if you can dodge cancer and you can dodge a lot of these things, that's really how you age gracefully.
I'm hearing a lot about cellular mitochondrial information that is.
yeah. You need to join Pennington as well, along with Alex.
So we,
Okay, I was,
You're-
yeah.
your agent, I call it health span, because you want your health span and your healthy years to be as good as possible. And that's really what we call anti-aging. The only other thing I will say comment is on, like they said, is I would be very mindful of what supplement, the statements on supplement bottles and on websites, et cetera, because they can make very generic claims that go well beyond what I would consider the true, what the research actually showed.
Yep.
And then something like probiotics, we were arguing the other day, a very popular supplement said there's more, healthy bacteria. Well, that's not even how we would report it in a normal journal or anything like that.
Yeah.
So you're being told something's great when we wouldn't even look at it in the same way.
And John, the crux of this, and I'm sure everybody in this room would agree, is that we're getting mixed messages right now. Now, we're not talking about vaccines today, but that's just a part of it, right? So be careful. You really got to do your homework here. Talk to your doctors to see what they say. They're really good.
Are there studies going on in Pennington about health, longevity and?
We have a variety of different studies. What specific studies, we have them broken down into 8 or 10 different compartments. And so I don't know all the different studies going on. We usually have about 70 to 90 studies.
We have a booth here that can
Yeah.
answer a
We
lot
have
of your
about
study
70 to
questions.
90.
Yeah.
They have longitudinal studies.
Studies
They
as
have
well,
the
yeah.
Bogalusa Heart Study, which
Yep.
is a study following people in Bogalusa for like 60 years. So that's the big one.
Yep.
And then we also have a lot of brain disorders of aging, because if you're talking about anti-aging, you can't differentiate the dementia epidemic we have, because what good is it going to be if you live to be 90 and you can't change your underwear in the morning, right?
There's a booth somewhere that.
Yeah, the Pennington has a booth downstairs that can answer your study questions for
Yeah,
sure.
and the site also has
Yeah.
all their clinical trials
Yeah.
listed, broken
Yeah.
out into those
Yeah.
categories that you can go browse.
Yeah, including if you want to volunteer for a study.
Right.
Yeah.
Yep.
Perfect.
Love to have you.
Or for Men's Health, next year if you want to help, do this. I have a few more minutes before I give these guys a break before our 10:30. I did want to touch a little bit more on testosterone stuff. Just y'all had mentioned it some, and I just want to talk a little on symptoms of testosterone and low testosterone and what that would look like.
So, low testosterone, can mask or mimic a lot of other disorders. So a lot of the common, complaints are just general fatigue. Over the last 2, 3, 4 years, I just got to where I get home from work, all I can do is sit on the couch, put my feet up. I used to get out and cut the grass, this, that, and the other. Lack of motivation. Just lack of energy or lack of willpower to get up and exercise or do things with the family, etc. Loss of muscle mass. Sometimes erectile dysfunction. Sometimes it'll mask as depression. I had a friend of mine who was an ER doc who said he had himself on Zoloft for 3 years till he finally checked the testosterone. He said, I got on testosterone and 2 months later I was off of Zoloft and never took it again. And his was just more of a lack of of motivation to do things. So those are a lot of the common. You start hearing the motivation, the lack of working out, or the loss of muscle mass, general fatigue, lack of interest in sex, or poor libido. Those are all common factors. And now testosterone is such an easy test to obtain. It's cheap to obtain. It's cheap to treat. Bob has any other comments in his practice as far as presentation?
Yeah, I would offer some cautions, right, with testosterone, because a lot of the patients that we see, a lot of the men that we see are asymptomatic. They don't have any symptoms at all. And when you question them, they're feeling pretty good and their life's pretty good. So you can't always base it on symptoms. And you can live without testosterone. Millions of men with prostate cancer who have been treated are evidence of that. So it's usually quality of life. And as Dr. Gilbert said, there's important references to your bone and muscle. So one of the things that I would really recommend for the gentleman here is we don't focus on bone density enough and osteoporosis in men, but it is a real disease, and that's certainly where you will see testosterone playing a big role. So if you've had a fragility fracture or anything of that nature, it would be a good idea to talk to your doctors about maybe getting a bone density to see where you stand. Thank you.
Any other questions on that? Okay.
How much testosterone do women need compared to men?
So it's small in amount. So if you think an average premenopausal woman by lab will be I think you get the increments right, but it's about 20 to 80 is it milligrams per deciliter, I think, something like that. Where the average man premenopausal or pre-aged is going to be 250 to 400 to 600. So about 10 times as much for a man than there is for a woman. We do sometimes replace testosterone in women. I always say kind of the premature surgically induced menopause, premature menopause, or high-functioning perimenopausal women. I typically only do it in a topical form because I don't like the idea of the shots of the pellets. I think we get levels that are too high in females. And typically I'm replacing like 2 milligrams a day to 4 milligrams a day by gel when we do it in females.
I've got a testosterone question.
Sure.
Yeah.
I'm doing replacement. What is best? Because you hear all kind of, is it better to do it once every 6-7 days, or break it down every 3 to 4 days, taking an injection?
I think once a week is adequate. Yeah, the old days of these, you'd hear these guys that had a patient the other day came in and told me he was going to the doc once a month and getting, the average man probably makes about 400 to 600 milligrams of testosterone in a month, and that's broken down over a month. And I had a patient the other day that told me, he said, he was going and getting 2 cc's, which is 400 milligrams, IM once a month from his primary doc. And he said, man, and this guy's an ex-college football player, he said, man, he goes, 3 days after I get a shot, I want to fight King Kong. He goes, at the end of the month, I'm writing poetry, So he said, taking that scenario and just simply say, okay, you're going to do it at home, and we're going to give you 100 milligrams a week. So I think when you do 100 milligrams a week, I think it's long enough that, we don't have to get these big peaks and valleys. It keeps things fairly stable. Sure, if you check a testosterone level, today and you did a shot yesterday, it's going to be higher. I usually check them kind of a trough level. As long as the trough levels are in range, PSAs are normal, blood count doesn't go up. I don't think you need to get any more frequent than that. I don't know that there's any data. You'll find anecdotally a few people will tell you they feel better by doing smaller doses more frequently. Generally about 400 to 600 milligrams a month, broken down weekly to 100 to 150 milligrams a week is what I do on the overwhelming majority of the time.
All right, guys, we're going to have another session. I want to give these gentlemen a break before our second session. You're welcome to come to session 2 and ask a few more questions. So let's give these guys a round of applause.
You guys know your stuff.